everyone, so welcome to another video in Think Like a Medical Registrar series. I'm Vishal Kumar. Welcome to the channel if this is the first time you've come here. So, like always, today we are going to be discussing a scenario where you'll be learning a topic which is going to be catered towards MRCP PACES and also towards general life itself. Okay, let's get started. In this video, we're going to be covering the scenario itself. We'll start off with that, then we'll go on to the bit where you tell me your plan, okay? You're going to tell me what you think is going on with the patient based on the scenario and the information we have so far. And then you're going to tell me what you are going to do about it, okay? This is all to get you into the mindset of PACES, into the mindset of real life, so that you can become that independent medical registrar that your consultants, your examiners want you to be, okay? And then we're going to move on to some key considerations of the scenario before we talk about how we reached the diagnosis and what are the key aspects of the scenario. And then finally, before we finish, we will talk about the bite-sized bundle for PACES, which I'm going to give you right at the end. So we will review the entire topic and I'm going to give you on one slide everything that you need for the entire topic. So make sure you stay with me until the end. You're going to learn loads, okay? Every time you see this bell icon, then make sure you follow my instruction and pause the video. Have a think about what I'm trying to get you to do to get the most out of this video. So here's the scenario. We have Matt. Matt is a 24-year-old fit and well man who regularly goes to the gym, okay? Past medical history, he has chronic back pain. Other than that, he's been fine. For the chronic back pain, he has had facet joint injections previously, about a year ago. All right. So this case, by the way, this case is based on a real life case that I saw at one point in my life. I remember this very clearly, which is why I'm sharing this with you, because I think there is a lot to be learned from this case. Okay. So let's carry on. He has been admitted with generalized muscle pains all over the body, okay? No particular distribution as such. He takes paracetamol and codeine, PRN, as required, okay, for the chronic back pain, not necessarily because of the muscle pains. Muscle pains have started in the last few weeks, about 4 weeks or so, although they have been overall ongoing for about 6 months, he says, but have worsened over the last 4 weeks, okay? He denies use of any anabolic steroids or other over-the-counter medications. Important because he might be using non-steroidals, for example, or other medications. He might be using other hormones because he goes to the gym, right? He's a young man. Who knows? Maybe he's a bodybuilder. We don't know how he got his chronic back pain. Maybe he is a serious bodybuilder and he did his back from that, right? We don't have that information, so we can't assume anything. We have to keep an open mind. Alright, but he doesn't say he uses any steroids or any extra supplemental medication. Okay, fine. So what do we have? On admission, the blood tests show the sodium is 139, potassium is 3.9, all good, normal. Urea is 4.3, creatinine is 78, so all good, and EGFR is above 90, so renal function is perfectly fine. However, the creatinine kinase is 8,799. This is grossly abnormal, grossly elevated, okay? This is a huge number for creatinine kinase. Something is going on here. The hemoglobin is 118. Normal is 130 to 145 according to the lab in this particular hospital, okay? So 118. And the MCV is 98. So that's normal, but the hemoglobin is not. So the abnormal things here are the fact that he's got a very raised creatine kinase and he's anemic, but it is normocytic anemia. It's not microcytic anemia, it is normocytic anemia. Okay, so this is interesting because he's not just complaining of muscle pains. There is actually evidence of damage to the muscles, isn't that? There is evidence of some kind of muscle loss activity because of the release of creatine kinase. Okay, but not only that, he is anemic as well. So definitely there is an underlying pathology. There is something going on here. The question is, what? Okay, so what is your plan? What do you think you would do at this point? Have a think and come back to this video. So this is what happened. We progress on and we see that on examination, the heart rate is 89, blood pressure is fine, 138/72, perfectly acceptable. There is no rash, okay? If you thought that you were going to look for a rash, here's your answer. And it is a very good thing to think about it in this sort of demographics, in this sort of presentation. I think it's quite reasonable to think about whether or not the patient has got a rash. But there isn't. The gait is normal as well. Okay, so clearly the back pain, whilst it may be bad, it's not affecting him to the extent that the gait is abnormal. Okay, so there is no tenderness over the muscles. There is no obvious tenderness as such either. Okay, and there are no oral ulcers. Now, for those of you who are doing PACES, you will know the significance of oral ulcers. They often suggest, most commonly, systemic lupus erythematosus. It can be due to other issues as well, like Behçet's disease as well, okay? But there are no ulcers in this case. So basically, there is nothing. This slide tells us that everything else is normal, right? So other than the fact that he's had muscle aches, creatine kinase is raised, and he's got normocytic anemia, we don't have much else so far. All right. So what do you think are the differentials based on this information? What are your differentials? Have a think, make a list, and come back. So I think a reasonable set of differentials would include some of these. Have a look. Polymyositis, so damage to the muscles, inflammation in the muscles, generalized, could fit in this picture, couldn't it? So that's possible. Dermatomyositis is also possible. He doesn't have a rash though. That's what we were talking about earlier. So you typically would get heliotrope rash like that, right? Kind of like pandas, but they're not exactly panda eyes. You get rashes around the eyes. So that's what dermatomyositis is. So, and you would get pain in the proximal areas, in the shoulders as well. Dermatomyositis, possibly, maybe. Systemic lupus erythematosus. Lupus can present in any shape or form in, well, pretty much everyone really, any adult, right? Even the most obscure presenting complaints can be due to an underlying lupus. Lupus, other infections like syphilis, for example, are known to be very notorious for presenting as literally anything. Okay, so you have to keep an open mind about this and still look for this. But lupus has got a very specific diagnostic criteria which you should know about. You can easily look this up. It's based on 11 different criteria. Okay, it's called the American College of Rheumatology criteria for lupus. And also, could it be polymyalgia rheumatica? Maybe. So the key thing that you need to remember about polymyalgia rheumatica is that the demographic is usually the older patient, okay? So the older patients, 55 and above, are more likely to have polymyalgia rheumatica. He is 24, okay? He is less than half the age of people that get polymyalgia rheumatica. So this is very unlikely, really. I wouldn't really put this down as a potential differential. I would definitely put down the top three, though. I think it's quite reasonable in PACES to think about the top three. But hang on, something doesn't quite fit, okay? The rheumatological screen that you sent off has now come back and it's negative. So you start to do a bit more digging now. You put on your detective hat and you try and find a bit more information. And here's what happens. You notice that his voice is hoarse and that his neck seems rather full. Okay, so young man, he's got a hoarse voice and that his neck is rather full. So that's not quite right. And he has reported some weight gain. So he is someone who goes to the gym quite a lot. He doesn't use anabolic steroids. But he's mentioned some weight gain without any change in his diet. Okay, so this may be a hint that's pointing you towards the potential diagnosis. When you examine him, you decide to do a full neurological exam because you think that you might be missing something here. And this is what you find. You find the reflexes are particularly slow. They are slow, relaxing reflexes. Tell me the diagnosis. If you have got the diagnosis and if you said this was hypothyroidism, you are right. Well done, doctor. So basically, his TSH comes back, thyroid stimulating hormone comes back with a level greater than 150, and the free T4 is less than 0.03. Okay, this basically tells you that he is profoundly hypothyroid, that he has not got any thyroxine on board, basically. Okay, that's basically what it tells you, and that he is experiencing all these symptoms most likely because of that. Then let's go back to Matt. What did he come in with? So he is a young and fit man. The only issue that he has is chronic back pain. But he's now come in with diffuse myalgia all over his body, no particular distribution pattern, not proximal, not just distal, not just one myotome, nothing. It's all over the body, okay? Generalized muscle pains. And a sky high creatine kinase, CK, is very high. And he's got normocytic anemia. So normocytic anemia is the most common type of anemia you can find in hypothyroidism. So that's important to remember. There are no rashes or other rheumatological features which would suggest an alternative diagnosis towards the rheumatological side of things. And he's got slow reflexes. And he's got a full neck, which is suggestive of a goiter. Okay, he has actually had a change in voice, and this is actually because of the growth in the goiter. Okay, and he's complained of weight gain. So this means that he has essentially got all the hallmarks of hypothyroidism. Okay, so what happens next? He gets started on levothyroxine and he gets discharged with endocrine follow-up. Rightly so, I think. Okay, I hope that makes sense. So let's see. What is the management then? We have covered a few aspects of this already. The management is basically replacement. They are deficient in thyroxine, so you give them thyroxine, you levothyroxine. You wouldn't normally start on a very high dose because that can essentially precipitate anything underlying. So you start on low dose and titrate up. Okay, so 50 micrograms is usually quite reasonable to start on. You then check their autoantibodies because autoimmune causes of thyroid diseases are the most common. You check for thyroid autoantibodies. You also look for evidence of other autoimmune diseases that are often paired with autoimmune thyroid disease, like Addison's, for example, and type 1 diabetes, for example. Okay, so Addison's, you look for that by doing 9 AM cortisol. You look for type 1 diabetes, you check the glucose, you check the HbA1c. Okay, that's what you do. All right. So, and after you start treatment, you would then, of course, check to see if it's working, if it is working enough. Okay. So you would check the thyroid function again in approximately anywhere between 6 to 12 weeks' time. It is essentially at the discretion of the endocrinologist, logistics, etc. Okay. There's no point checking it too soon because it wouldn't work. There's no point checking it 3 days down the line, for example. Okay. And then you titrate the levothyroxine based on the repeat thyroid function, because then that will give you an idea to compare whether or not you need to increase the thyroxine higher. Most likely, in a lot of patients, you do. So you would increase the thyroxine higher and recheck again. All right. So that's essentially overall the kind of management. And if there is an underlying cause for it, which we'll explore some of in a bit, then you treat that underlying cause as well. So here we are now at the bite-sized bundle for PACES. I hope you found everything so far useful. We are now at the end, which is going to be the most useful bit, so stay with me. The first thing I want to talk about is the demographics. So the demographics for patients for hypothyroidism is actually in the higher range, okay? It's usually 40-45 plus. Patients younger than age of 40-45 don't usually get hypothyroidism. They don't. Okay, so to find that in a 24-year-old man is very uncommon, but this actually happened to me, and this can happen in your PACES exam as well, which is why it's easy to forget that, and it's the reason why it's very important for you to remember this, okay? Because these patients, once stabilized, can be easily brought in to your exam, and they can easily be your patients. So the demographics are the older patient, okay, not necessarily the younger patient. Just this is the general demographics. In terms of the causes, the most common cause worldwide is iodine deficiency, okay? In the UK, in the Western world, this is not the case, but worldwide it is iodine deficiency. In the UK, the most common cause is autoimmune. Hashimoto's or atrophic thyroiditis is the most common for hypothyroidism in this country. Okay, so that's what you have to remember, guys. Autoimmune is the most common cause. So primary hypothyroidism caused by autoimmune and autoimmune etiology. Okay, drugs are also liable to causing hypothyroidism. Commonly, lithium and amiodarone. So amiodarone can cause hypo or hyperthyroidism. So you keep an eye on the thyroid function if a patient is on amiodarone. Okay, if a patient has had cardiac issues and you note that they've had weight gain, any signs of hypothyroidism, you should always be checking their thyroid function. Next is infiltrative diseases. These are, of course, much less common. Stuff like sarcoidosis, hemochromatosis, and amyloidosis. In the history, this is what you should be asking, okay? If you get a few of these, then you should definitely be looking out for thyroid disease. First and foremost, weight gain and constipation, cold intolerance, low energy or libido. They just feel generally lethargic and tired all the time. They don't feel themselves. Their sex drive reduces. Menorrhagia in women. And if they have got any kind of goiter symptoms, then they may have issues with swallowing, change in voice, they may have a fullness, okay? In terms of the history, this is how I remember it. Thyroxine is required to keep your energy levels up, to keep your metabolism up, okay? So it drives things, it makes things speed up. So if there is a lack of that means that your body slows down. So when your body slows down, your weight picks up. And when your body slows down, then your bowels slow down and you become constipated, okay? And when your body slows down, then you become you have less heat, therefore you feel colder, okay? And your energy levels are lower. So everything is less, okay? Everything is slower. That's how I remember it. I hope that it helps you as well. So in terms of the examination, looking at the hands and feet, you may well find something called myxedema. And in this patient, you would have actually found this. He had puffy myxedematous hands and feet. Skin and hair, you will find that they have got dry skin and hair loss. Okay, not hair growth, hair loss. Things go down, remember? Reflexes, oops, spelling mistake there. Spelling mistake. Reflexes, they will be slow and relaxing. Remember, everything goes down, not increases, so reflexes slow down as well. ECG will show bradycardia. Things are slowing down, remember, so ECG shows bradycardia. In patients who are hyperthyroid, the opposite happens. They may well go into sinus tachycardia or atrial fibrillation as well. Okay, but we're not talking about that. We may well talk about that another time. So keep an eye out for that. In terms of the chest x-ray, they can well develop pleural effusions. In fact, they can have transitive pleural effusions, and that is one of the causes of transitive pleural effusions, hypothyroidism, okay? Other causes are stuff like congestive cardiac failure, for example, or hepatic failure, for example, okay? Pericardial effusions can happen as well. Typically, pericarditis can happen. Also, on the blood test, the key things that you should be looking out for are raised TSH, thyroid stimulating hormone, and depressed T4. Okay, so that's the pair that you need to be looking out for. That's the absolute key thing in this slide from this presentation that you need to keep an eye out for. Okay, and also thyroid antibodies such as anti-TPO antibodies. This stands for anti-thyroid peroxidase antibodies, which would be suggestive of Hashimoto's thyroiditis. Raised creatine kinase or cholesterol can also happen, as we discussed earlier, and of course, normocytic anemia. So I hope that this is helpful. Make sure you take a screenshot of this, because I wish I had something like this, to be honest, when I was doing PACES. Would have really helped. If you found this helpful, guys, make sure that you check out my book on strategies for high achievers for PACES. It's out now on the Kindle and also the paperback forms. The link is in the description down below, and so is my course. Both of them are linked down below. I will see you in the next video.